Thank you for joining me today to learn more about how brief emergency department-based interventions can help prevent suicide among at-risk patients. Among patients at risk of suicide, the likelihood of attempting or dying by suicide is highest within the first 30 days after discharge from an ED or inpatient psychiatric unit. According to research, approximately 20% of people who died by suicide have visited an ED sometime within the month prior to their death, and up to 70% of patients who leave the ED after a suicide attempt never attend their first outpatient appointment. ED professionals are in a unique position to improve outcomes for those at risk of suicide. They can play a critical role in preventing future suicides and attempts by detecting suicide risk in ED patients through screening, by evaluating positive screens through comprehensive suicide risk assessment to determine the patient's risk level, and by providing 5 brief ED-based interventions. These interventions can be used both with patients who are awaiting inpatient admission and especially with patients who will be discharged from the ED. Emergency departments are challenging settings, especially when caring for individuals at risk of suicide. ED nurses, physicians, social workers, case managers, and other staff are constantly juggling competing demands on time and attention that can make delivering care to at-risk patients feel daunting. These 5 brief interventions can decrease suicide risk in patients, help patients manage suicide-related symptoms after discharge, and link patients with outpatient treatment. They include brief patient education, safety planning, lethal means counseling, rapid referral, and caring contacts. These interventions were identified by the Suicide Prevention Resource Center, a national ED consensus panel, and informed by the Joint Commission's guidance on preventing suicide in all health and behavioral health care settings. These 5 brief interventions are designed to be quick and are specifically for use by ED staff, including specialists or non-specialists. It is recommended that EDs provide more than 1 brief intervention. Providing these interventions jointly can have a greater effect on patient outcomes. As all EDs are different and dynamic environments, we encourage you to think about which of these interventions your staff can implement most efficiently and effectively in your particular ED setting. See the resources at the end of this presentation for more detailed information about how to implement each of these 5 brief interventions. With every brief intervention you provide, it is also essential to give patients a crisis center hotline number along with information about this service. If you don't have a local crisis line, give the patients the National Suicide Prevention Lifeline number on this slide. Let's take a look at each of the 5 brief interventions, starting with brief patient education. The patient's ED visit may be the best or only opportunity to provide a patient and their family members with important suicide prevention information. Brief patient education involves describing the patient's condition, treatment options, and what can be done to minimize suicide risk after discharge. One-on-one communication between ED staff and a patient is essential when providing educational information. You can also give patients written materials to supplement the information, but handouts should never be a substitute for in-person communication. Here are some key topics to cover during brief patient education. Explain that anyone can be at risk of suicide regardless of their age, gender, or ethnicity. Review risk factors including substance abuse, mental health conditions, or past attempt. Also review protective factors such as connections to friends or family and access to mental health treatment. Ask if the patient has access to lethal means such as a firearm and discuss the possibility of temporarily removing access. Let patients know that treatment is effective and can reduce suicide-related symptoms. It is key to convey that recovery is possible. Discuss the link between substance abuse and suicidal behavior. Tell patients about home care. Family and friends should be asked to check in on them. Discuss follow-up care and ensure the patient has an appointment with a mental health provider. Discuss what to do if their condition worsens. The goals of brief patient education are to reduce the shame around suicide, promote linkages with outpatient treatment, and to instill a sense of hope for recovery. More information on what to say when providing brief patient education is provided in the full ED guide, which is linked at the end of this presentation. Safety planning. Patients with suicide risk should leave the ED with tools and resources to help keep them safe. With safety planning, the provider and patient collaboratively develop a list of coping strategies and resources that the patient can use before or during a future suicidal crisis. It covers the following: the patient's individual warning signs, internal coping strategies that the patient can use on their own, such as deep breathing, a list of ways to distract oneself from the crisis, family members or friends who can provide support, professionals to contact for help, and ways to make the environment safe during a suicidal crisis. The plan should be brief, easy to read, and in the patient's own words. It is important to be aware that safety planning is not the same as a no suicide contract, which is sometimes also called a contract for safety. There is no evidence that contracts for safety are effective, and they can give ED staff and providers a false sense of security. Anyone in the ED can implement the safety planning intervention in written form or using a mobile app. We recommend developing and reviewing the safety plan together with the patient. Ask the patient for input on each item and help them brainstorm options if necessary. Identify any patient barriers or obstacles to using the safety plan collaboratively with the patient and discuss ways to overcome them. Communicate that safety plans are important for coping with suicidal thoughts or feelings, and that getting outpatient mental health care can address what's making the patient feel suicidal. Sample safety planning forms and safety planning apps can be found in the full ED guide, which is linked at the end of the presentation. Lethal means counseling. Over half of all suicides involve a firearm. Sometimes, a person's risk of suicide can escalate rapidly, and if a lethal method, like a firearm, is accessible to the patient during a suicidal crisis, it could make a difference between whether he or she lives or dies. Discussing ways to limit access to lethal means during a period of crisis with a patient and his or her loved ones can help save the patient's life. Any ED specialist or non-specialist can provide lethal means counseling. Here's what to do. Ask the patient at risk of suicide and his or her family or friends if the patient has access to lethal means for suicide, such as firearms or both prescription and over-the-counter medications. And if so, discuss with the patient and his or her family, friends, or outpatient provider ways of limiting access to these lethal means, such as temporary removal or storage, until the crisis has passed and the patient is not feeling suicidal. Rapid referral. Remember that within 30 days of discharge from an ED, patients are at highest risk of suicide attempt or death. With rapid referral, ED staff make an outpatient appointment for the patient to help ensure that he or she has follow-up care and support. Don't leave it up to the patient to make the appointment. Here are the action steps for this intervention. Make an outpatient appointment that ideally occurs within 24 hours, but no more than 72 hours of discharging the patient. Consider the patient's needs when scheduling the appointment. With the patient's consent, provide clinical information about the ED visit to the outpatient provider. If you are unable to schedule the appointment before your shift ends, identify another provider to follow up with this task. Troubleshoot any barriers that may prevent the patient from following up with the outpatient care, such as a lack of health insurance or transportation. If you are unable to schedule an appointment with a mental health provider within a week after discharge, schedule it with the patient's primary care provider and work with the local crisis center to provide follow-up support to the patient. Caring contacts. Up to 70% of patients who leave the ED after a suicide attempt never attend their first outpatient appointment. This intervention involves brief contact or communication with patients at risk of suicide after they leave the ED. It is meant to demonstrate continued interest in the patient's well-being and encourage patients to follow up with outpatient care and support. Caring contacts has been shown to reduce suicide attempts and deaths following ED discharge. Caring contacts should occur one or more times by phone, text, email, letter, or postcard. Other than phone calls, this contact or communication can be done by anyone in the ED, or it can be automated. Alternatively, you may want to establish an agreement with a local crisis center to make caring contacts with your recently discharged patients at risk of suicide. Let's review. Here are the 5 brief interventions specifically for emergency department staff to use with patients who are at risk of suicide. Brief patient education, safety planning, lethal means counseling, rapid referral, and caring contacts. With every brief intervention you provide, it is also essential to give patients a crisis center hotline number along with information about this service. And remember, providing more than one brief intervention can have a greater effect on patient outcomes. Visit the SPRC website at sprc.org/edguide to view more resources on each brief intervention, or click on the small information icon in the upper right-hand corner of this video to open a link to these resources on our website.